Okay, well, thanks, Kimberly, and thank you all for joining us. It's great to see so many people interested in this topic. I've been asked, what's the difference between the seminars and the workshops, other than the title. Our goal here is to make this more interactive than the traditional seminars that we've been having. And so first of all, hopefully you did the homework that we assigned to you in advance. We had a couple of papers to take a look at. We're going to have some breakouts where you have a chance to chat about one of those papers. I'm going to be posing questions as we go along, and we'll try to use some of the tools in Zoom and elsewhere to make things as interactive as possible. And as Kimberly noted, feel free to post questions or comments in the chat, and I'll try to keep an eye on those. Susan, who's with us, Susan Law from Trillium Health Partners, will also keep an eye on the chat and try to address obvious questions as we go along, and we'll try to come back to them at the end. So I'm just going to get my screen share started here, and let's see. And just get to. So we should have my slides up here now.
Yep.
And so I was reading the paper, and this is today's Dilbert cartoon. And I just thought this is perfect for our chat. So you don't need a mask for a Zoom call. Can you back that claim up with a randomized clinical study? I've noticed it's a lot easier to hate people lately. And I think this is one of the things about getting science into policy is people have questions about what is the appropriate level of evidence that needs to be considered for different types of policy decisions. And I think there's often a focus on the randomized clinical study. So we're just going to take a second to get to know who's in our Zoom conference today. And so we got our first poll up, and we'll give you a few seconds to answer the questions. Okay. Almost everyone has voted. Okay, Kimberly, why don't we end the poll? Okay. So we got a lot of people from Ontario, so we got our work cut out to get people from other parts of the country, but it's good to see we got people from right across Canada. Okay, was everyone able to see the results? Okay. So we'll go, sorry.
Oh, I'm so sorry. BC was not listed, and that was probably my error.
Oops, sorry about that.
It was not an intentional forgetting.
Yeah. Okay, so we might have a few people from BC, and I certainly saw some people from BC in my Zoom screen before we started. So let's go to our next question. Okay, Kimberly, I think we can end this. So we got about just under a third university faculty. It's great to see so many students, trainees, and postdocs. We got people working in government, industry, and not-for-profit organizations, and it's great that we have some patients and members of the public. And we have 12 people who weren't in any of these categories. Maybe as we have conversations, we'll learn about who some of those people are. So our next question is just to get a sense of what theme or discipline you're from. So Kimberly will go to the next question. Okay, why don't we close this one? And so none of the above is the most common category. So people didn't see themselves fitting into any of these 5. These are our 5 themes for CanCOVID theme leaders. So we recognize that not every area may see themselves as fitting in under the labels here, but there are broader descriptions for each. And again, as we go into some of the small groups, hopefully we can hear about what areas other people were in. And why don't we go to the last introductory question? Okay, why don't we close this question? And great, we have people across the levels that we described, and hopefully we'll be able to share some insights with people who are new to this. So we can take the poll off, and I'll just appreciate the comment from Rebecca. Obviously, the people in BC don't need any help on their COVID response, and and I'm sure Kimberly is very apologetic for having left BC off the answer list.
The irony is that I'm actually from the West Coast.
Yes. Okay, so let's, I'm going to just do a few introductory comments. And, one of the interesting things certainly has been written about is that if we compare perhaps with what's happening south of the border, in Canada, our leaders have been quite clear that they rely on science advice, they rely on medical advice. And I think by and large, we've had good connections, good presence, and there was just a recent comment, I think it is today's Globe and Mail's editorial, speaks to the fact that in British Columbia, the Premier tends not to attend the public health briefings. They're run by the Minister of Health, and there's great deference to Bonnie Henry in terms of actually answering all the questions. That's not necessarily the case everywhere, and again, we've seen how in the United States where we've had the president sometimes giving some very interesting advice to the public, including most recently on his treatment with Regeneron antibodies. But we've also have had comments about who are the scientists that are supporting. At one point, the province wouldn't even reveal in Ontario who was providing the scientific advice. There now is a science table that is hosted at the University of Toronto, and its membership is publicly available. But I think the other thing that's not talked about as much, which will be a lot of the focus for this session, is how do we decide what the science is? So when the Premier or the Prime Minister says we are listening to the scientists, we're relying on the scientists, we actually know there's often not a single consensus view on many topics. And so one example of this, and this was in the background readings, and if you had a chance to read this paper on false dichotomies and do the little exercise that we prepared for you, hopefully you would have thought about how the science, first of all, evolves over the course of a pandemic, and the science is not as crisp as the politicians might like to say, and that it is nuanced, that there's differences in views. And so in this paper on false dichotomies for coronavirus, they explored a number of these different dichotomies. And so what we're going to do, just so people have a chance to talk a little bit, and we're not just transmitting to you constantly, is we're going to assign you randomly into breakout groups using the Zoom functionality for that. We don't have facilitators. We don't have so you'll just be randomly assigned participants. We'll ask you to briefly introduce yourselves. This will be self-organizing communities forming. So you'll have to just hopefully not talk over each other. And we'd asked you to identify which of these 5 false dichotomies interested you, and prepare an elevator pitch for a Minister of Health. So when we're doing knowledge translation, we have to be able to communicate in language that's simple and is done in a short period of time. So that's the concept of the elevator pitch. And then take a few minutes to talk about what you sort of think about as you think about these different dichotomies, the spectrum of views that might exist on some of these topics, and what that has meant and what that means for getting science into policy. So with that, I'm going to ask Kimberly to place you into the groups. The co-hosts will pop into different groups at random to just check on how you're doing and address any questions that you might have. And we'll have you back in about 15 minutes. Okay?
Oops.
Let's give this a shot, Kimberly.
Yep. Did that work? Did people get the breakout rooms? Nobody's leaving. I think I did that wrong. Hold one moment, please.
We're all practicing.
Yep, I pushed the wrong button. My apologies. Here we go.
The traditional view of knowledge translation has often been a linear model where there's perhaps a mythical decision maker looking for the right place to find the evidence they need to support a decision. And somewhere out there, there's a researcher with results to meet the needs of that decision maker. And there's often a very linear model that is viewed, that is research, and it's going to get into the hands of decision makers. So we'd like to do another quick poll, and here some of the discussion that you might have might come in handy. So Kimberly's going to post the link in the chat as well, or you can just type this poll everywhere link into a browser window, and you'll have a chance to enter what kind of barrier you think is most likely to happen that gets in the way of that very traditional view, scientist to decision maker. Kimberly, can you put the link into the chat?
Yep, got it. Oops, sorry.
Okay, and then I'm gonna see if this works here.
Oh,
The link says that we need to have access.
I'm not sure what happened. Let me check that and get another one.
We need the exact text that's on the screen, actually.
Just
That
use the
works.
text on the screen.
It's not a hot link, so it won't activate.
No, you'll have to type it into your.
Yeah, it won't let me get the link up to post. Chloe, could you post the link in the chat? Thank you.
Yep.
Whoever just posted the link, that's the correct link. Sorry, it doesn't let me post from my own account. It tries to make you sign into mine.
Oh yeah, there you go. Yep. Oh, maybe not.
There's some great answers happening, so I know some people have figured it out.
Yeah, you need to get the app. Anyway.
Oh, it looks like you're on a phone.
Yeah.
So
yeah.
if you text that Kimberly Kolb 491 to 22333, you can text a response as well.
Okay. Will do.
So Kimberly, are you going to display the word cloud?
Sure.
Okay, so I'll stop. Can you put it up?
Yep.
Okay. Ooh.
Oh, language, that's so neat.
So it's interesting, time and language, see values, politics, communication, clarity, public, trust, confusing, bureaucracy.
I love the beliefs in quotation.
Yeah. Comprehension. So it's interesting. We got Twitter. So what's interesting is a lot are around the communications, the language. We got fear, which are values, which may be more related to the decision maker beliefs. And then we got the process sorts of items like bureaucracy, money. Okay, I think we'll end this.
Just stop sharing. Oops.
Okay. So as we just saw, there's really a wall often between the researcher and the decision maker, and we saw some of the examples come from all of you in terms of the things that can affect it, the media, politics, the views of individuals, what they read, the views of the politicians. I'm just going to take a quick detour through some of the research that I've been involved with over the years that gets at some of these issues. And first of all is the nature of evidence itself. This work I did with Ross Upshur, Elizabeth Van den Kerkhoff was a postdoc at the time. I hate to say it, I'm dating myself, but it's over 20 years ago. We were part of a network that had a goal of improving the use of evidence and decision-making in all levels of the healthcare system. It was known as HealNet. It was one of the networks of centers of excellence. And what we realized was people were coming from many different disciplines and actually had different conceptualizations and definitions of the term evidence. In the cartoon I displayed at the start, we talked about randomized controlled trials, and people that came from a clinical research paradigm believed that randomized controlled trials were evidence and the highest form of evidence. We had legal scholars in our network that had a very different conceptualization of evidence, and we had philosophers and fundamental scientists, each had their own definitions. So we did a major review of the literature and came up with a conceptual basis for thinking about how to categorize evidence. I won't go through this in detail. Those of you that are interested, the reference is here, and we will make these available afterwards. But we really talked about the fact that there's both quantitative and qualitative evidence, measurement driving quantitative evidence, and meaning or understanding the qualitative. And we can work from the individual level to the population level. And when you start to think of it in this way, the evidence-based medicine paradigm is very much based on this sort of quantitative approach to population analysis. And if you focus only on that, you can leave out getting the evidence about what people might value, what individual experiences might be, and what the context or the resources might be. And so I just include this to note again, when people say we're relying on the science or we're relying on the evidence, they actually have to be clear about how they're defining the evidence and which kinds of evidence is being included. For truly evidence-based or evidence-informed decision-making, we have to bring in evidence from a broad range of disciplines and paradigms, and that's one of our goals with the CanCOVID network. The other piece of work I'm going to talk about is work that Mark Dobrow did as a PhD student with me and Ross, where based on that, we thought, okay, how is all this different types of evidence actually incorporated into the policy process? And what Mark did was actually research the development of different types of cancer screening guidelines, where what I was observing was the decisions that were made were often not actually tied to the level or strength of the evidence that might have come from an evidence-based paradigm. And what he really showed is that if you only focus on that evidence axis, you ignore the political or context axis. That is, what are all the other factors that enter into a particular decision process? And we posit that the evidence-based health policy tries to get the balance between evidence-based or purely scientific decision-making, purely political decision-making, get the balance. And you'd want to try to move upwards towards this quadrant where you're considering both the context and the evidence in the decision-making. And what he also showed is that there's not a single simple point at which evidence gets introduced into the decision process. So again, we often think, okay, here's a piece of research, let's find the decision it fits into. first of all, there's actually not a single decision point. Decision making itself is a process that happens through many steps and is often iterative in how it happens. And evidence can get introduced into the decision making at many different stages. And at each of those stages, there can be both external factors as well as internal factors in terms of the organization or body that's trying to make the decision. In the case of this research, we were looking at consensus panels that had been put together by Cancer Care Ontario. And so there was the ways in which those panels operated and the ways in which the external bodies, the Ministry of Health, the professions and the other organizations involved were operating. And the other important thing is that there's sort of formal processes that we could document and see in the decision making of the panels, and very direct channels by which evidence was entering in. But there were also informal processes, or another way of framing that would be the things that happen outside of the consensus panel. And as people have conversations on the side and share things and so on. And so again, if we really want to think about understanding how evidence gets into a decision, we need to think about all these different factors in the different stages at which it happens. And the final piece of work I want to talk about is some work based on this earlier research when we were in the middle of the H1N1 pandemic. Laura Rosella and other colleagues at Public Health Ontario, we actually did a series of case studies on decision making during the pandemic process, and essentially confirmed all of the things that Mark had modeled in his earlier work, and furthermore, as we're seeing right now and was highlighted in the other reading that I provided, is that all of the things that we saw in the more traditional decision-making processes happen very rapidly in sort of rapid cycles when we're in the middle of a global emergency, such as the COVID-19 or pandemic H1N1, which was certainly not anywhere near like what we are experiencing right now. So I would certainly encourage anyone that's more interested, we will share the references. And I think in the interest of time, I'm going to skip the next exercise and we'll just keep going. And I'm just going to now quickly go through some of my own perspectives on what have been some of the successes and some of the challenges in bringing science into decision-making during this age of COVID. And the first thing I want to just talk about is we've actually been very fortunate in having a lot of science. So this is a slide I put together back in at the end of June, and all of the competitions that got held in the first 3 months in Canada. And in Canada, we actually spent through the end of June close to $2 billion on COVID-19 research. And just think about that for a second. That is the annual budget of CIHR. So in a few months, we put into one disease as much as goes into all of health research. And we're not the only country in the world that has done that. There was a remark that the growth in publications about COVID-19 was almost as fast as the rate of growth of the virus itself. And this rate has actually continued. The last time I checked, there's about 600 papers a day being published on COVID-19. So the challenge becomes from going from not having much science at all and much knowledge of the virus to having a tremendous amount, and how do you actually keep up on all of that? And then, as some of you noted in the comments, like that science is being shared with individual research papers being out in the media and in the public attention almost immediately. So the normal process would be things are discussed, debated, we have sort of the raw elements of evidence going out there. The other thing, which again, I'm saying both of these are really good things. We have a great volume of science being produced, and we have a great degree of open science. So again, a major success during COVID-19 has been the degree of sharing of both results as well as data. The genetic sequences were shared almost immediately back in January, which enabled the development of the tests and the work on the vaccines to start quickly. But again, a challenge has been that with having lots of material come out as preprints, it's out there in the public domain, and it's being debated in the media, on Twitter, and people often don't have a full understanding that those papers have not gone through peer review yet. And so these become challenges for the process of incorporating evidence into decision-making, because the people trying to do that incorporation are constantly facing the fact that all this information is out there before it's even been digested, appraised, and sometimes peer-reviewed. And I'll also note that even when there is peer review, we've seen many high-profile retractions, and I'm sure everyone's familiar with hydroxychloroquine. We saw Donald Trump promoting it based on some of the early evidence, and these are two of the very early studies, Lancet and New England Journal of Medicine, that were later retracted. Yet we have other examples where people continue to cite that kind of research even after it's been retracted. The next area that I want to talk about is all of the biases that enter into decision-making processes. And I put this picture up because we have Robert Redfield. Most people don't recognize him, the head of the Centers for Disease Control, and Anthony Fauci, the head of the NIH Institute of Infections, who's been, I'm not sure what his role is now, but was the president's senior advisor. In the United States, he essentially became the public face, and he did a tremendous job. But his experience and his background came from infectious disease and clinical medicine and basic research, whereas Robert Redfield came from the world of public health. Very different paradigms, very different experiences that are brought to the decision process. And in the paper that I had written, or the commentary I'd written, I talked about the medicalization of the response. And the reality is that that brings a certain set of biases and perspectives to the decision making. These biases were highlighted in a paper in JAMA that came out in the summer. Scott Halpern spoke at one of the earlier CanCOVID webinars about this, and goes through a number of biases that have been present, and really speaks to this medicalization, prioritizing visible, the cases that we see now, as compared to the more statistical probabilities of what the consequences might look like. The tendency to optimism, hoping that there'll be a new rapid test or something else that will come along, as opposed to thinking about what we should have been doing for the last 6 months and preparing for the second wave, preparing for the additional lab capacity that we're going to need. So these are, I'm not again going to go through all of these, but there are many well-known biases that have been out there that we've seen in very much in real time throughout the COVID decision-making process, that again influences the decision-making and sometimes results in science, or not all the science entering into the decision-making process. And these are some examples of some of the sort of what I would frame as decisions that were made that might have been pushed by these biases, putting a lot of effort into making ventilators. I have great respect for Art McDonald, and don't put this up to be critical, but we started making a lot of ventilators because back in March, that was what we were very worried about, and we didn't maybe think about some of the other things like contact tracing and testing that we really needed. We built in the UK, they started to build out all these hospitals, which all wound up sitting empty. And the sort of the hope for a silver bullet, I think now we're starting to see the reality of what it will take to get a vaccine set in for people. But I think for many months early on, there was a view that we don't need to do a lot of preparations because a vaccine's going to come quickly and save us. And certainly south of the border, that continues to seem to be the narrative. I'm certainly very hopeful that we'll see a vaccine in the coming months, but it will be a vaccine. It'll probably take longer to get vaccines that are efficacious, that don't have side effects. But the critical thing is going to take time to run a global immunization campaign to reach the 70 to 80% levels of immunity that will be required. And so we need to be thinking in our decision processes and thinking about the science that's needed to support the decisions that will help us through the long haul. Some of you mentioned the role of social media, and I think Twitter was one of the things that came up in the word cloud. Sunatra Gupta is an epidemiologist at Oxford who's been critical of some of the orthodox thinking about the management. I don't necessarily agree with everything that she has to say, but this article was a really fascinating read because she felt that social media attacks were basically being used to try to shut her down in her ideas. And that's chilling the kind of scientific and policy debate that we need to have. If we're actually going to get to sorting out those false dichotomies, we need to have debates about them, not try to shut down people who have different views. And, one example that I just walked through quickly is this issue of airborne transmission. You'll remember back in July, there was an open letter signed by many scientists from around the world. About the same time, there was a paper published in JAMA that really confirmed what the WHO and the CDC position was, that aerosolized transmission was not a dominant means of transmission. There was another open letter signed by another few hundred leading scientists published in the same journal as the first one, which refuted this. All of this is sort of going out in the media and in the public eye and winds up being very confusing. This week, CDC released its updated guidance. The headlines say it confirms airborne transmission, but when you actually read the entire document, it's much more nuanced and says, yes, this might be possible, but the droplet transmission remains the dominant means of transmission. We've also seen high profile in the media around survival on surfaces. So very early on, there was this letter in the New England Journal of Medicine, which suggested that it could survive for up to 72 hours, the virus. And this got picked up very significantly in the media. And then later, a few months later, Emmanuel Goldman from Rutgers in The Lancet published a paper where he didn't say that the science was faulty. It was actually well done research in that original New England Journal of Medicine paper, but it didn't actually get at real world conditions. The amount of virus inoculum was much, much larger than you would normally have in a droplet, included some of the culture media that the virus is grown in. So it's not surprising that it lasted for 72 hours. The real world evidence actually doesn't suggest that transmission from surfaces or by fomites is actually a credible means of transmission for COVID-19, yet people continue to wash their groceries and do things like that based on some of that early evidence. And my favorite example is this modeling work that was done by an aerodynamics engineer in Belgium, suggested that runners could transmit the virus a great distance. and was again not based on any clinical evidence of transmission. The person who did the study actually said he never intended it for it to be interpreted the way it was by the media, yet it continues to be out there and is the basis for many people's decisions. For example, we see people running and wearing masks. So, why does this happen? So if we think about the amount of research that's being done, the number of transmission events that there have been for COVID since late last year when COVID first came into humans, we're going to find outliers on the normal distribution. So when we say the dominant means of transmission is by droplets, there is transmission from aerosolized particles, and there's transmission from surfaces. It's a normal distribution. We're doing tons and tons of research, and you're going to find papers published that will be out here and papers published that will be out here. What evidence synthesis is about is bringing all that information together. And the policy decisions really need to be framed on the synthesis of evidence, not on the individual papers. And I think the challenge that we're having in the time of COVID is it's those individual papers, letters, and so on that are getting into public discourse, and people aren't waiting for the synthesis, which happens through the normal process of science. The other thing that I think common in terms around language came up quite often in the word cloud that we did, is that as scientists, when we write those papers, we tend to be very careful in our language. We usually try to stay away from being definitive about causation. So we'll rather say the evidence suggests this or that. And so that leads the interpretation perhaps to be a weaker one. And a good example of how we can maybe change the way in which we present our science. That don't expect you to read everything in this box. Noni MacDonald from Dalhousie with Andre Picard from the Globe and Mail wrote this paper over 10 years ago, where they took the Institute of Medicine statement on the relationship between MMR vaccine and autism. So this has been the basis for a lot of the anti-vaccine arguments over the years. And it's a long sort of drawn out statement, and said, this can be presented the same content in a much simpler language. And so these aren't things that we normally do as researchers, but we can work with people who have the expertise in taking what we put together when we do an evidence synthesis, framing it in a way that is more readily understood and incorporated then into policy processes. So I've come to the end, and we have time for some discussion, and we'll ask people to either use the raise hand function or to pose any questions or comments up as in the chat. And I'll start by reflecting on, Amin has posted, in today's political climate, we may not be able to preclude policy-based evidence. And I absolutely agree. And in fact, what we need to understand is that is the way sometimes that decisions are going to be made. And so Kimberly, we don't seem to have the raise hand option. So just if you want to ask a question, just say in the chat that you want to ask a question. And we'll sort out how we can get it onto the participant list. So in terms of the policy-based evidence, what I would say is really important is sometimes you make a decision because you don't have the science, and then policymakers are going to have to do what is informed by what's available. But there are circumstances in which decisions are made in the face of having clear evidence, but people from a policy perspective, based on resources, based on values that people might have expressed, make a decision that's not in agreement with the science. And I think in that kind of circumstance, what's really important is that there's transparency and that people say, we considered this science, here's why we chose not to make the decision in that direction. I see, Amin, you have your hand up. Do you want to comment on this further?
Maybe something related. Sometimes there are unintended consequences. For example, this is based on my reading about stuff that has gone on in the UK, where there was a big push for local lockdowns rather than a national lockdown, with the argument that if you don't lock down some severe cases in time, then you might have to lock down the whole country again. But one of the unintended consequences is that the high incidence of cases are often in very low income areas. So therefore you're hurting the poor the most. And sometimes that consequence is overlooked in the healthcare angle alone. And therefore, you know, the wealthy in the wealthy neighborhoods can enjoy their no lockdown, whereas the poor who can least afford it are forced to lock down. That's all.
Yeah. Yeah, and I think that really speaks to, I went through some of the background work very quickly, but those are some of the contextual factors that have to actually be considered in decision-making processes, in the sense that it might be very easy to say the science says do this, and for most of the population that will work, but if you don't consider the context of all of your population, you may have inadvertent effects for other people. And so I think a good example during COVID was if you're exposed to someone, you should isolate yourself and shelter in a separate room and use a separate bathroom. And, you know, I think most of the people sitting around the tables making those kinds of recommendations probably live in households with multiple bedrooms and multiple washrooms, and it's, you know, to them it seemed very natural to say that. But when we think about you describing, you know, the neighborhoods that we've seen where we've had more cases, those are neighborhoods with dense housing, multi-generational households, and in fact, we're also the neighborhoods where the people that were working in essential services are living, because they tend to be lower income immigrant families. So they didn't have a place to go and isolate on their own and have a separate bathroom. If you're living 8 people in a 3-bedroom apartment or 2-bedroom apartment, that's theoretically, that's a very nice recommendation to make, but that's not something you can implement. And so now we're looking at policies like having isolation facilities for those types of people. So I absolutely agree that the broader context has to be considered alongside of the evidence, and then we have to say, how does the evidence play into it? Patrick has asked about in the urgency. I'm not sure policymakers have the luxury to wait for traditional knowledge synthesis, meta-analysis, Cochrane review. And again, I absolutely agree on that. But they also cannot be swayed by individual papers. And that's really my main message. And so that's where the pressure is on us as a research community to figure out how we can do those sorts of things faster. And our goal will be in future sessions of this workshop series to actually walk through how some of those things like evidence synthesis and creating summaries in simple language are being expedited during COVID-19, and how we can share some of that information with people across the country.
Vivek, can I just add?
So I think, sorry.
Sorry, I was just going to add to that. I think that there's both the evidence synthesis part, which we can do faster, but it's also, as you alluded to, it's also where that connects and intersects with decision makers, because you know, with the poor communities, the sad part is that a lot of that could have been predicted. But you know, even though that knowledge might have been known, the people at the table making the decision thought, oh, you know, sheltering at home, everyone can do that. So, you know, there's both the synthesis part, but also the communication part, and who gets to participate in those discussions.
Yeah. Yeah. And so, you know, I think what you're speaking to is, again, and again, once we get into an emergency situation, like, I'm not going to fault the people who did those things back in March. They were being forced into making lots of decisions very quickly. So I think that's just the reality in how things happen. But, you know, for example, now I know in Ontario, and I'm sure it's the same across most provinces, the patient family advisory councils are being engaged, different community groups are being engaged, and we're starting to see those sorts of things. And I think the lesson is that as we think about the emergency response structures, we need to ensure that there are checkpoints as things are being put together with people from diverse backgrounds and diverse communities to ensure that that is being heard. But I would be the first to say that, you know, if you've got 4 hours to make a decision, it's the same as your comment. You don't have time to get a Cochrane caliber systematic review done. And you may not have time to get a full consultation done. But if we actually have the paradigms ready, hopefully people will think about it. And it also takes me back to my comments about having a population health perspective. You know, I think a lot of our decision-making, not just in Canada, but globally, has had much more of a medical model, which looks at the individual patient and looks at the individual as opposed to the community. Again, I'm not disparaging, I'm not saying that's wrong. We need to have the balance between the two as we're making the decisions. So a really interesting question from Nico Shepard-Jones about the precautionary principle when synthesized scientific evidence is not available, and masking for source control is the example. So first of all, precautionary principle, for those that may not be aware of it, is the point that in the face of something unknown, where the risks are not well understood, the action should be to have the most protective measure put in place. And with respect to new emerging infectious diseases, on the protection side for healthcare workers, until we know, for example, what the transmission characteristics are of a new emerging infectious disease, the advice is use the most appropriate protection, the N95 mask, for example, when doing procedures and interacting with patients. I think the issue on masking for source control, and that was one of the things in the false dichotomies paper, is that was something that, based on the experience with previous viruses and so on, was not well understood, sort of the nature of transmission for SARS-CoV-2. And you know, I think people's experience with influenza and other viruses perhaps influenced the early responses from public health officials about that. And so, you know, the whole concept of source control, that is, rather than the protection of the healthcare worker or anyone from the virus, is actually keeping someone from transmitting the virus to others. And I think, again, just in fairness to the public health authorities, that's something that really evolved in real time. And I would say, you know, maybe people could have moved to those decisions a week or two earlier. But in the scheme of how fast science evolves and how fast policy evolves, I actually think in Canada and Europe and most parts of the world, I'll put the United States aside, the shift to use of masks for source controls actually happened pretty rapidly as that science emerged. and got pulled into the decision-making process. So we've got a lot of questions and just a little bit of time left. I'm going to go to, I think I see a hand up from Steve. So maybe we'll take a question verbally and then we'll continue with some of the questions in the chat.
Hi, Vivek. Thanks, Vivek. I just noticed your first question there, and thinking back at that enormous amount of money that got flowed, you know, for COVID-19 research, and knowing how competitive it is to actually get research funding nowadays. It just seemed to me that there was an enormous scramble in the research community to finally get some of that research that you wanted to have done, and people were just sort of, you know, structuring their questions around the funding that was suddenly available. And what I do wonder is whether or not there was a bit of an obligation in the community, perhaps, to prioritize, you know, to think about what is the research that is most important to do at this time. What is a reasonable sort of research agenda for Canada? Are we actually the place where a vaccine is going to be invented, or are we a better place to be running sort of therapeutical clinical trials in our, you know, practice-based research networks to actually do a little, I don't know what forum there is, and maybe perhaps this forum that we're in right now is the forum where that should have been happening or could have been happening, and maybe it was happening. So anyhow, that's my question is there a role within the scientific community to sort of prioritize and agree amongst itself what are the areas that we could actually have an impact and a difference, you know, through our research?
Yeah, and so I think that's why I put that point there is that, first of all, you know, and I think cultures and attitudes have really changed, but if I think back to 25 or 30 years ago, when I first started as a researcher, it wasn't really expected, unless you really wanted to do it, but it wasn't expected of people to even think about what their contribution to society was. Your role was to generate the research, and it's someone else is going to figure out what to do with it. And what this is really getting at is it's not just about generating the research, but do we have a role in actually framing what the most important questions are and how we best address them. And, you know, I think I've certainly in other sessions, I've said, you know, when I use that slide that I put up, we got some great science funded, but did we get the right science funded? And I think by February, the WHO had posted priorities for COVID-19 research. Certainly when CIHR did the first and second calls, they referred to that, saying, you know, show how your research fits in there. But there wasn't really a framing of what is the priorities for Canada. And I think your point is really important, like sorting out, are we going to be the ones to do this? Should we be focusing our efforts on things that help identify what works in the Canadian setting, what's going to work in, say, for example, remote or northern communities, things that are very specific to Canada. I think for university-based researchers, we traditionally don't like to have directed research, right? We don't like to have competitions where we're saying, here's what to do. We say, let's have investigator-oriented, initiated competitions. But I would actually say in a situation like this, it does make sense to maybe have some processes where the science community works in collaboration with government to figure out what the priorities were. And the original motivation for creating CanCOVID back in the spring was to be able to have those kinds of conversations. And it took a while for, you know, again, they were so busy with so many things, it took a while to actually get it supported and funded. And it is certainly going to be part of our role, not to do it on our own, because there's many bodies within government. There's the Immunity Task Force, Vaccines Task Force. So we're actually working in collaboration with the other groups, with the Chief Science Advisor's office as well, to start to think through how some of that priority setting could be done for the research, and then also how to best conduct it, because to the point about getting things done quickly, sometimes running competitive processes and having the same team doing the same similar projects may not be as efficient than having people come together and work in a collaborative way. And we also need to be able to decide quickly what not to continue. So, you know, there's multiple trials were funded through those early processes on hydroxychloroquine, and they may have scientific value, but are they the most important things for us to be working on? There's a few questions here about the role of the public and patient and user advocates, and certainly I think I touched on it with the comments with Patrick as well. Yeah, I think if we're not in a pandemic, our systems have been starting to better structure processes so that there are patient or public representation on consensus panels, on review panels, and so on. Certainly a lot more work needs to be done. And I think, again, lessons out of COVID are going to be, how do we do that kind of engagement from the front end, right from the start of the work on the processes. And one of the comments is having patient and user advocates on every team. And that's certainly been years ago when I was involved in breast cancer research with the Breast Cancer Foundation, we had breast cancer patients on every research team. I think when that first started, the scientific community was very uneasy about it, but it actually, I think everyone that had those experiences realized how much better their research questions and their approach to research was by having that kind of engagement. So again, I think that's something that we've already talked about as we move forward with CanCOVID. Maybe in one of our future sessions, we can talk about best practices and approaches to engaging different communities. And we just have a couple of minutes left. So a comment from Priya about how has social media fueled policy during COVID-19. I think I gave some examples of this, and certainly I think the most significant thing is through social media, the science, the individual raw science sort of moves very quickly, and this can change, first of all, how decisions are made, because the science is sort of, the individual science is driving things. And I think, as in your example here, you know, the Premier in Ontario certainly articulated that people should, anyone who wants to get tested should get tested, and that's a policy that continues for some time, I think driven by requests coming in on social media. And I think the upshot was that now when we got to the fall wave, we wound up with the testing lineups. So any other, I don't see any other hands. So it's great. I think we have a lot of dialogue here about community engagement and different perspectives. And so we'll certainly take that and look to maybe some of you might be interested in volunteering to organize a future session around community engagement. And so David Hall, I think, has a really important point about the research priorities, and certainly in the CIHR calls, in both COVID calls, there were, the reviewers were asked not only to do the science review, but were asked to assess the relevance from a priority perspective. My own sense is not everyone, because we're not used to doing that in traditional peer reviews. We're not asked to do that in traditional peer reviews. So I think we have work that needs to be done to prepare people to be able to make those kinds of assessments. And I think the other challenge with the two special calls was we didn't have panel discussions, even virtually. And I think something like relevance and priorities is probably better suited to having a discussion within the panel. So we'll make sure we take a copy of the chat, and I'll go through, and we can certainly, if I haven't had time to get to everything, but I appreciate the level of engagement that we've had. apologize for a couple of the technical hiccups. We're all learning and experimenting with doing things virtually. We've wanted to try to do this in a little bit more engaging way, but it also resulted in a few hiccups. Certainly feel free to send your feedback and any comments and how we could improve things for the future, as well as other topics that you would like to see community workshops on. Kimberly, any closing comments that you have?
No, I just want to echo my thanks for everybody for coming and being such amazing participants. Thank you so much.
Great. Well, thank you, everyone. Goodbye.
Have a great evening.